Freddie Quack. I'm chair of this BCS Digital Divide Specialist Group. Some of you know about the BCS. For those of you who do not know, the BCS is, I love the BCS purpose of making IT good for society, right? And we're all IT professionals here, many of us. And this specialist group is about leaving no one behind, because with technology, we've been moving way too fast, and we need to make sure that we also take some responsibility of helping others to come along this journey. And for today, we're very delighted to host this webinar. We do a webinar every month, and we cover a range of different topics. Today is about AI use in health and social care. And we're delighted to have 5 speakers today. And I'm going to get each speaker to introduce themselves. But very quickly, I want to mention Rosie Woodhead over there. She's a digital strategist with over 30 years working alongside the NHS. So I'll let her tell you about what she's going to talk about today. We also have Beata Green here. She's a technology leader for Athena AI. So she's clearly doing something in AI. And her colleague, who's not here in a moment, is called Adiola Ajayi, who's a product owner, part of the same organization. We also have Matthew Douglas. You do a lot of stuff, yeah? Digital infrastructure at Cambridgeshire and Peterborough NHS Foundation Trust. So, and then of course online, we have Violet Rook, who is the editor of the National Pensioners Convention. She's going to write up about this event too at the end of it. So I'm really delighted to have this panel in front of me. Without much further ado, I'm going to hand it over to Rosie to kick us off and tell us why you want to tell us about this thing from your perspective. Oh, I'm sorry, before we do that, I forgot one very important person. This person standing in front of here, she's the reason why this is happening. So this is Maureen. Say a few words. Why did you do this?
I did this because I meet so many people who are having great difficulties. My age group, especially, I've had some disastrous experiences with the medical profession of late. And as you get older, you have more medical problems, and it's becoming quite disastrous now in National Health Service. I put this group together because I'm actually rather pleased that you've come along. We were hoping for a larger audience. Some people are filtering in now. Because we're pleased that you're as interested in AI in health and social care as much as we are, because we're quite worried, and so is the general population. As you know, Keir Starmer is hoping that Great Britain will lead the technology field, and also we're all very anxious about National Health Service and the waiting lists and all other problems associated with the National Health Service. And everyone's looking at AI as a panacea to solve all these problems. But of course, we're all very worried about the actual results that AI may produce. There are there's some wonderful research going on, and they're using AI to collect all the data, as you know, and the data is evolving every day. Every time a clinician fills in the forms that they're required to fill in, that all goes into the collection of data that the clinicians are using to help solve problems. But of course, we've got to keep it centered on human beings and their needs. And we mustn't rush everything to do with just the administration, because there's the pitfall, the rushing, who tend to leave out the human being.
So, thank you, Maureen. And just so you know, she's a champion of not only AI, she's champion for older people. Use technology for good. So thank you, Maureen. Yeah. On that note, Rosie,
Sit here or go outside.
please sit here. I'll be the one.
We need you.
We need you
It's
here.
not, it's not that I'm trying to exert.
Okay, so Rosie, over to you.
Thank you so much, Freddie.
I'm just hoping more people will come in.
Thank you so much, Freddie, and the BCS for inviting all of us today. I'm Rosie Woodhead. I'm an independent consultant, but I have over 3 decades, 35 years of experience within the NHS and with the NHS as well. I've worked on lots of different strategies, digital programs, transformational and change programs across both primary care, secondary care, acute care, community care, and corporate services as well. And I'm still doing it. I can't stop myself. I've got to still keep them going. So let's get straight into it, shall we? So what will I be talking to you about this evening? I'm going to talk to you a little bit about modern general practice and the challenges faced by both general practitioners and their patient populations across England. So it's your first point of call with any condition you have. I'm going to talk a little bit about the plan set out to help those practices and their patients to improve access to care as the first point of call. I'm going to touch a little bit about online consultation systems that are available to be better utilised by practices and their patients as well. And I'm going to share some of my experience and findings with a case study I'm actually working on at this present moment in time. So what are the challenges within the primary care? So this is quite well documented, whether it be in the press or NHS England, as they are at the moment. And one of the key challenges is around demand and capacity. There's intense pressure on primary care. GP practices and their teams right across the country are facing intense resource and workforce pressures as the need for patient care increases, the complex cases, etc., long-term conditions. While at the same time, the GP numbers, our clinicians, are dwindling. So these challenges are often acute practices in areas of high deprivation and often in many areas of rural areas around the country. So why do we need to move towards a more modern general practice? What is it all about? Isn't this another buzz phrase that's come out? But no, actually, no, we've been doing it quite a long time. We've been doing a lot of quality improvement work to help better access over the last few years. So why call it modern general practice now? So let's take a step back and think about the existing processes and protocols in place. The first come, first serve model. That's a big challenge within primary care. So I'm going to split it in a bit 2 parts. Patient perspective. We are all patients here. We need to access our GP. We call first thing in the 8 o'clock in the morning to try and get an appointment. And it's frustrating because that 8 a.m. rush, and we're often told to call back the next day. And that can be frustrating. It can also be very worrying. When I get an appointment when I need one. It's also an unfair model because a lot of the allocation of appointments can disappear within the next first 15 minutes of phone calls opening or the front desk opening. It's also quite confusing for patients. Things have changed in my practice, but I don't know what's changed. There might be new services, I'm not aware of them. And I'm not sure how it all works now. It's all confusing. So of course, as a patient, I'm going to get frustrated and angry. So these types of concerns are reflected with declining patient satisfaction surveys that a lot of practices conduct every so often. So that's the patient impact. And that's quite key for us all. What about the practices and staff? How does the first come, first serve model affect them? So it carries quite increased clinical risk from higher volumes and complex needs as well. Practices aren't able to see all the demand that's coming through because it's all haphazard and they can't plan their workload effectively. That's why we don't seem to get appointments when we want to. And also, practices find that they don't understand the patient needs fully because they're not capturing it more effectively. And of course, they can't prioritise it more effectively either. So all of this encompassed into sustainability risks at primary care practices and GP practices. And that's in the face of increasing demand, challenges in recruitment, losing and retention of staff. Staff attrition is really high in practices. We don't realise that because from our perspective, we need to see our GPs. And if there's not a GP there, what are we going to do? And of course, burnout. Burnout is really high in general practice, GPs burning out, working too long an hour, which it can actually have a ripple effect on patient care. So in comes modern general practice. What's this all about? What are the aims of a modern general practice? What is it? So I'm going to give you a smidgen of what it is. This particular model is available. If you want to look at NHS England's website, you can actually put modern general practice in, and it will give you a really good, in a nutshell, flow diagram on what the modern general practice aims to do. So the key objective is to improve patient experience of access and allocation, improve staff working environment, and better align existing capacity with need. So that's their aim. How are we going to do it? So what does the practice need to do? So for the practice, from the practice perspective, there are some key tasks and stages that they need to actually look at and actually take a step back and actually look at the root cause analysis. They need to understand their contact channels, from patients accessing by picking up the phone. Hey, I'm not feeling well, I need to see a doctor, through to online submitting queries and requests through online channels, or actually turning up at the practice to say, I'm not well, I need help. Once they look at that, they can actually structure that in a way that they capture as much information as possible to create a single workflow, so that our clinicians can assess the needs of the patient, prioritize more effectively, and better align existing capacity with the needs of the patient, rather than a first come, first served model. But that just doesn't stop there. It also is a continual improvement. So if they put this model in, they're not to say, hey, tick box, we've done. It's not all about that. It's how do we continue to improve that? What about if there's a new service that we're going to have to deliver to all of our patient populations based on their needs? How are we going to do that? We need to be effective. We need to be proactive. So yes, that's all well and good. This is what the practice needs to do. That's the plan all the way through. What about patient experience? What's in it for you and me when we contact the practice? What's going to be different? Am I going to be still in a queue? Well, actually, if the practice has done all of the structured elements of capturing the right information from us of what our condition is, what our needs are, look at our patient records, enable clinicians to be able to assess our needs more effectively, patients will be directed more effectively, navigated to the right service at the right time, and see the appropriate clinicians that are available. So that's all great with the strategy and the planning, etc. So how does technology fit into this? So online consultation systems is one type of technology that practices currently utilize to enable patients to be able to send in their medical request or non-medical requests as well. Prescription requests, all sorts of things that patients can submit. So how can these online consultation systems and patient systems that are already available be better utilized by practices? Because currently it's the processes and the protocols in the practices that need to be refined a little bit to actually meet that demand more effectively and efficiently. So from a GP perspective, if they were to utilize the current systems that's at their fingertips more effectively, they can clinically lead their assessments, prioritize more effectively, and allocate appropriate consultations rather than bringing a patient back and forth into multiple appointments. And it cuts down that unnecessary telephone consultations that they have when a GP calls you back, or an in-person visit as well. So some systems as well that are out there, and I'm not going to name all the systems, there are loads of systems out there and they're growing as well. These systems are growing as we speak. Some of these systems have embedded AI capabilities to help highlight red flags, assist in triage clinicians, in prioritization of urgency of requests, and enabling diagnostics as well. It's all well and good, but it's still in its infancy. Not the full functionality is not fully adopted as yet, but it's available. It also helps improve continuity of care, allowing GPs to focus on critical cases as well. So that's quite important as well. And it's better integration. Now, these systems, we also think about integration of systems and online consultations does integrate really well with a patient system where our normal medical records are stored, and patient records are updated effectively and in real time as well. And that's a really good plus point about utilizing this particular technology. And of course, it enables two-way communications between the GP and their patients, and they can talk to them in real time. So there's no delay in effect. So how does it help patients? That's great practices. They've got all the tinkering buttons and all the toolkits that they need to deliver that particular care. But what about for patients? It's greater accessibility for patients. Requests sent to the practice can be captured through all those different access channels. Even through, if you're walking in and saying, right, I'm excluded, I haven't got a tablet, I haven't got a phone, I don't know how to submit a request, people will be able to capture that same information at the front desk. So the practice will be trained up to actually guide patients who are digitally excluded. It will hopefully reduce waiting times, eliminate that first come, first serve model, quicker access to medical advice rather than having to wait on the phone to give you some advice, and reduce those appointment delays as well. Online consultations also enables advice, information, self-referral, self-booking capability, so continuity of care. So if you needed a nurse's appointment, you can book yourself into a nurse appointment. You don't have to wait to be on the phone or, you know, be directed through to the appropriate clinician. And routine management of your ongoing care. So continuity of care once you've been diagnosed and you need extra help, care, on the referrals. Online consultation enables that to be able to access it more effectively, access those services more effectively. And we can see that as patients through our practice website. NHS app is actually also linked up really well, so you can submit it in all different forms. So with that in mind, I just want to share a few outcomes from an active case study that I've been working with a practice, because I go out and actually speak to practices, work on their strategies, and actually get them to take a step back and think about their processes and protocols and build in effective systems so they can actually utilize all the technologies available to them to enable their patients to get access to the care that they need. So this particular practice, their challenges were all the different areas that I mentioned at the beginning, and then some. And there's a whole list. I'm not going to go through the entire list. There's not enough time this evening. The top three that I jumped out at me: practice morale was being affected and existing capacity could not be sustained. That is quite big for a practice. The volume of unnecessary GP appointments booked in were high. Now, taking that nationally in England, the percentage of appointments that are unnecessary appointments that are booked into GP clinics sits at 20%. This practice was higher than that. So you can see the challenges they were facing. Non-clinical staff were struggling with the demand from patients and where to direct them. So it's very hard for reception staff to direct patients if they don't have the right training, the capabilities to know where is the patient going to go if we don't know what do we do with them. So from those challenges, we built a whole protocol, and that protocol was called the clinically led triage system, which captures this information from a structured process, filters those requests more effectively, assigns a clinical medical request to a clinical triage team led by GPs. So GPs do the assessment. It doesn't go to reception. Reception capture that information and, you know, filter it out effectively. Non-clinical to admin, clinical stuff goes to the clinicians to assess it more effectively. And those clinicians can then effectively prioritize and allocate or advise accordingly using the technology at their fingertips. So what were the outcomes? So there were a list of outcomes, lots of outcomes. But again, I'm going to tell you about the top three outcomes. This practice is now live with a clinically led assessment service as they promoted to their patients. They didn't really want to tell their patients triage because triage can be think, oh my God, am I an A&E? So clinically led assessment service, or CLASS, we decided to call it, a 4-letter acronym. We love it in the NHS, or 3-letter acronyms. Their triage model. And the clinicians just come back and said, we're not going back to the old first come, first serve. We've got back control. We're seeing who we need to see. The positive impact on the reduction of their avoidable appointments or unnecessary appointments, they were at 34%. And after the first month, we re-looked at the data, it went to 0. Clinicians were saying, what a month we've had. We haven't had one unnecessary appointment coming into our clinics. We are seeing the right patients at the right time. We are managing the needs of our community more effectively. And the other outcome, what about the patients? They're improving how they communicate with their patients. The patient feedback was so low at the start, it's gone through the roof and saying, wow, this is fantastic. I'm actually going to see the clinician I need to see or the service I need to see. So that's really effective. So what's next for this particular practice? I asked them, well, what's next? They said, well, actually, we're thinking about AI workflows. So I said, what do you mean we're looking at AI workflows? So actually, to help support our clinical team with their diagnostics even further, we need to utilize AI a little bit more. So I, as a word of caution with the practices, I said, hold on, take a step back. You need to understand how effective that's going to be. Small steps, take small steps, see what you've got now. But the reason why they want to look at their AI workflows is to help look at the red flags that long-term conditions can raise and be able to deal with them more effectively, looking at their records to be able to manage conditions that need, I'm not clinicians, but you know, to need to be sort of like dealt with more effectively and more efficiently. So in summary, for GP practices, effective and efficient processes are key to continual improvement and sustainability. Online consultations are key enablers. We've got to remember that technology is a key enabler to provide us with the best care possible and best access possible. And they can be better utilised and integrated more effectively. Patients are better supported through effective clinical assessments. And from the patients, better accessibility, improved communication through all contacts that are available to them, including supporting digitally excluded communities where it's needed. Patient experience improves when their clinical and medical needs are assessed more swiftly and more appropriately. My final thoughts for you all, by enabling, my words are going today, my final thoughts, by enabling better utilisation of online consultation systems, we can empower GPs with effective and efficient tools, enhance patient care and access and experience to the right care at the right time. Hopefully, we're able to continue to create more accessible and sustainable healthcare for all. And remember, small improvement steps can lead to bigger and better outcomes. Thank you so much.
Thank you, Beat. Thank you. Thank you. That's the joy of having a physical event, because then you can get the sort of applause from the audience. Yeah. Now, next we have Beata Green. So over to you. Please say a few words about yourself, who you are, why you do what you do.
Yes, so a pleasure to meet you all here, and thank you for coming. So I'm Beata Green, and I am a CEO of a small startup, Atina Care. Atina is a platform that helps family carers to look after older adults, and in some cases helps older adults to look after themselves. So I'm going to say a bit about my background. I'm a technologist. I also run a healthcare technology company, and I have been a chief technology officer of a large healthcare organization before the last 2 years. And why I'm saying it, because I've done technology for a long time, and I got the job as a director of a large technology department. And I thought, you know, I know what I'm doing, but believe me, healthcare is a different beast, because you deliver technology as normal, there is a certain process, but in healthcare development, there's so many other things you have to take into account. There is how you develop your software, because it has to be clinically compliant. How you then put it in a cloud, there's so many different rules. And you know, the worst one was, how do you test what you've done is right? Because you can't test with real patients' data, or you can't see hardly, you know, any details about your patients' data. So how do you know that the innovation you are producing is going to work if no one has the access to data? So there were so many challenges. And on top of it, when you deliver it, you also have the approval waiting time from the NHS, which, you know, on average might be a year and a half, sometimes 2 years. So anyway, the reason I'm saying it, just to state it, that those were my challenges, but also this is the time where I fell in love with healthcare. So I will talk about today using AI in care, in social care. I'm really passionate about social care, and I'm working with Ati as well. I have my older mom and my older aunt, and lots of our friends struggle with similar type of issues, looking after older adults. Yes, so that's where the passion comes from. And to put it in a context, in the UK, there are 5.8 million of family carers currently, whether looking after the family member or a neighbor or a friend. The care industry in 2024 was worth 11.5 billion to the UK economy. I mean, it's an amazing issue. So I definitely believe, and Keir Starmer believes that as well, that AI and technology, smart technology, can really add value and can resolve some of the challenges which a lot of us are dealing with. So I wanted to talk about 3 areas, and specifically very specific areas. So first, AI in helping to schedule and manage the appointments, doctor appointments. So and the opportunities which technology can bring here. So I will create a persona of Mr. X. Mr. X is 70 years old, male, living on his own, suffering from multiple conditions, has a daughter living nearby, a son living abroad, and a circle of friends. Has to attend a lot of GP appointments, a lot of hospital appointments, has to have a lot of tests done, lots to follow up. And apparently, a lot of issues that result from this is that people just don't remember about the appointments. Older adults, either they don't remember about the appointments or they can't get to the appointments. So where AI can help us here? Well, first of all, it can help us track all of these appointments. It can help track, it can help to remind through either the technology or a voice-enabled mechanism. It can also inform the circle of friends and families who is possibly due to take that person, to Mr. X, to that appointment. Not only this, but it can help Mr. X and the family prepare for these appointments by suggesting the documents or lab test results that need to be taken. It can also give questions for the doctor to ask, because people often don't know what questions to ask, specifically older adults. When they go to the appointment, asking the correct question, and more so remembering what the doctor said, is a challenge. AI can also listen to the conversation with the doctor, take notes, summarize it, and feedback into the system for everyone else to see, the family members to see. It can even book a taxi. So there are a lot of things which can be streamlined through the use of AI. There are a lot of questions around usability, and I will touch on them later. But ultimately, what I just wanted to highlight is that there are certain, that in this context, AI can be the super efficient organizer. It can be super efficient reminder and generally keep control of this appointment. The other area is medication management. So specifically for older adults, 1 in 5 of them will end up in A&E because they either not taken enough medication, they have taken too much medication, or they possibly are taking so many different medications that they suffer from pharmacy issues. So again, AI can come handy for reminders for all of the situations of not taking enough, taking too much. AI can alert family members or the carers, and AI can also check for any polypharmacy issues. So if you suddenly got, challenges with 5 different medications and possibly they don't go together well, there can be an alert saying, okay, you need to check it with the doctor. When the stock gets low, AI can also send a notice to your pharmacist saying, please renew my stock, and the medication will come to your house. So there are these different elements where AI can be very handy. And another situation which we came across is that in a lot of situations, paid carers who come and dispense medication complain next day later that when they left, the family members didn't remember to give that medication. There were at a loss what to do. So yes, again, AI can be seen here as your personal pharmacist, which either can remind, I mean, we're very keen on AI using the voice, can remind about the correct dosage and correct timings. And the final area is well-being, but we talked about well-being before, but specific area which gets a lot of investment now is preventative well-being, preventative health. So a lot of us have watches, we can see our vitals, body vitals and measurements, and we can get alerts when some things are not right. But preventative healthcare for older adults focuses more on predicting when things are going to go downhill, and doctors are very keen on it. How do you predict then in a week's, 2 weeks' time, someone is going to fall or faint? Well, that's a much bigger thing. So the technology, I'm not claiming to be an expert on it, but technology behind it is very complicated because it's not only takes the reactive vitals, but it also takes data from socioeconomic environment, but also things like how were you moving, how Mr. X was moving, is his pace slower, is his sound of the voice slightly different, what is the frequency of the bathroom usage, and with all of this crunching of data, the AI is able to predict. Apparently there are solutions predicting it with 90% accuracy, that in 2 weeks' time Mr. X is going to have a problem. So yes, so those are the sort of main highlights. There are a lot of questions around how we make technology usable. You know, how someone, for example, who had stroke and is not communicating clearly with AI, how is AI going to understand and interpret? There are all sorts of issues around this and around, you know, where do we stop? How do we sort of then are compliant against the medical compliance bodies? But that's a separate probably discussion.
Thank you, Beata. Let's give her a round of applause. We'll do it at the end. Right, next, I'd like to invite Adiola Ajayi. You work with Beata.
Yeah.
Again, say a few words about why are you doing this role and in this specific area?
Yeah. Hi, everyone. So my name is Adiola. I'm from Nigeria, and I've spent the last decade building technology companies. And by profession, I'm a product manager. So I'm the one that sort of works with the engineers, guide them on what to build, and ensure that it actually meets the user need. I sort of specializing from going from 0 to 1, meaning like we have an idea, we don't know how it's going to meet the user needs, and I help sort of guide that process. And today, I think I wanted to like take a step back when talking about AI and sort of talk about why this is such an important moment in history. And I'm going to talk a bit about why it's such an important phase, how it all started, more importantly, what are like the common things AI is being used for within the care space specifically. And lastly, I'll talk about the concerns that we've observed and noticed. So currently, I'm a co-founder of Athena AI. Myself and Beata have been working together for about 9 months, almost 9 months, a year. Yeah. It's like weird, right? How time flies. Yeah. And we've learned a lot. Why I'm so interested in this space was like Beata sort of has more exposure in it, and she dragged me in. We're having user interviews, and we literally see people cry during these conversations. Like they have to care for their older mom or their older parents, and people are really struggling with some of the challenges around this. I've been thinking, how can we create solutions that can actually help their lives? Well, first and foremost, why is AI so important? Why is there so much buzz and noise about it? I think in order to give like a good comparison, I would first talk about the Industrial Revolution. Now, what does the Industrial Revolution have to do with AI? It's quite surprising, but they actually have quite a lot in common. You see, in the Industrial Revolution, everything that was a physical, manual, or laborious task was being replaced from a human being to a machine. In the artificial revolution, essentially what's happening is that everything that is a cognitive-based task that is repetitive can actually be replaced by artificial intelligence. And you can actually sprinkle it across almost every single industry, just like electricity or like just like machines, right? It applies to almost every industry that exists. So that's really what makes it very fantastic. So let's compare, for example, the UK pre the Industrial Revolution. 75% of people actually used to work within the agricultural sector or were farmers. Across the world, about 8% of people were either farmers or work within the agricultural value chain. Today in the UK, it's less than 1%. And 1% of the population is generating food and generating all the output that everybody consumes within the same society. So a lot of the jobs that existed pre-industrial revolution has largely changed. And I think the big worry is like, what are the jobs of the future going to look like? I personally don't know. I think that's one thing that I constantly obsess about, and I'm sure we'll figure it out, you know, hopefully. So now we've mentioned that, you know, basically how did it all start? It's quite interesting, but AI has been existing for more than 70 years. But the real breakthrough happened in November 2020 when ChatGPT was released. I'm actually quite surprised. The audience I was expecting looks very different, but how many people here have actually used ChatGPT in the audience? Everyone. Yeah, like, can you picture your life without ChatGPT today? I personally can't. Yeah, I can't imagine what like my life would be with. I use it like every single day, even when I want to send a text to my wife. I'm like, what should I? Yeah, but that's how embedded it is in everyone's life. And this is like just 2 years, or you know, about 2.5 years just post-launch. Imagine how integral it's going to be in everyone's lives in next, you know, 30, 40 years, or, you know, 10 years. 30 is a far period of time. And there are like 3 major areas we sort of seen challenges around, like artificial intelligence and challenges in social care. You know, when Beata mentioned 3 areas, I was scared. I was like, wait, hope it's not my 3 areas. But there's a bit of overlap, but I'll talk very briefly about them. I think the first one was like social isolation and companionship. It's quite unfortunate, but like the society is very, very isolated, and we've seen people to be incredibly lonely, and people are trying to create all kinds of interaction, like this event we're having here, something to just bring people together, but it can't happen as recurrently as people love it. And what we've seen is that artificial intelligence can be a way to sort of subside that gap. Fortunately, it can never replace human beings, but now we're seeing all kinds of softwares that can just act as a companion to just interact with people, especially older people, especially seniors that literally, you know, they're retired, they need some form of engagement in their lives, they need some form of activity. And these bots are actually trying to fill up that gap by just saying, hey, it's time to wake up, like go to the gym, or, you know, maybe take a walk, not go to the gym, take a walk, you know, make a few steps. And we're trying to see how like all of these things can actually create an impactful solution in people's lives. The second area that we've actually seen to be very helpful is daily task assistance. Today we're speaking with someone whose mom has dementia. And apparently there are 2 kinds of dementia. There's one where it's a gradual decline, and there's one where it just dips. Terrible with the names, but and it's really unfortunate how like people lose their cognitive abilities and things that they were able to once do. They are completely unable to do it. And I think what's really sad about technology of today is that it's relatively new. So for example, things that people could do has changed significantly. Let's say, for example, you know, pay their taxes or perform some form of activities. The process has changed. Whereas they used to have to go to the post office to go and send a letter. It's right now you send an email. So there's a lot of exclusion due to technology. And unfortunately, a lot of people are being excluded. So we have to find ways to make this technology, to make these services accessible. And fortunately, AI can actually be embedded within their daily tasks to assist in some of the activities. So today we're saying things like voice controlled timers for cooking, where you could basically set a meal on the timer and say, hey, put it off when it's the certain temperature. And we're seeing fridges that could restock itself. And we're seeing like medications where it could actually like check the weights. And once it's below a certain number of drug items or pills, it actually reorders them. So we're seeing all kinds of application within the second bucket, which is like daily task assistance. The last bucket is like health information and management. I think this is the part where we've seen the most amount of exclusion. So today, let's assume someone has a life-changing medical condition. An example is stroke. One of our team members, her mom suffered from a stroke, and basically you lose a lot of your cognitive abilities in that moment. And unfortunately, when you go out of a hospital, they give you tons and tons of leaflets. That's actually the worst time for you to be reading stuff. You just need the specific information on certain things right now, and you can go and like learn the rest later. And that's something that we've seen artificial intelligence to be incredibly helpful for. It can provide the specific information that you need at that point in time. And it can keep guiding you on, hey, it's 1 week after your stroke. These are the specific things that you need to know. Let's assume like you're below 50. It's going to know that you probably need to get back to work. And there are certain kinds of activities that you need to perform in order to be able to get back to work after a stroke. And artificial intelligence is incredibly helpful to be able to take all of that information that is personalized about you and give you structured guidance on how to get back to your regular routine or your, the quality of life you were once used to. So it's incredibly valuable for getting health information and, personalized guidance. I think to just close up, I'm just going to talk about some of the concerns we've seen. And I think they're in two major buckets. The first one is in privacy, and the second one is in inaccuracy. I think privacy is such a big bucket here because everybody's concerned about their data and how it's being used. I think it's a two-edged sword because on the first side, you need to actually provide all this data for you to get personalized response. But the other side of the sword is you don't know how it's being used. And personally, that's something I don't even have an answer to, and I can't really advise on. I think the last part is about inaccuracy. Today, Beata and I still work with these kinds of technology, and we're exploring things every day. And there's a lot of hallucination. And I guess the feedback on that is that we're still in day one. Like this technology is barely 2 years old, and everybody has really high expectations of what its capabilities are meant to be. But we constantly have to remind ourselves that like before even electricity, AC and DC got to the state and level that it currently is today, it took decades. And artificial intelligence is still on day one. It's barely 2 years old. It's 70 years old, but it's barely 2 years old in terms of practical use. And it's only going to get better and better and being embedded into other areas of our lives. So thank you very much. Hope you do.
Thank you. Thank you, Adola. Next, we have Violet. Violet, can you unmute yourself and first introduce yourself and then tell us what you want to tell us?
Hello, everybody. I'm Violet Rook, and I'm involved with the National Pensioners Convention, which, as you can gather, is for older people at pensionable age. And I was a deputy editor, and I'm the editor of the newsletter, which is called Connections for All. And this is about we deal with stories which are about inclusion in regard to digital technology and exclusion, and about the worries of people really in regard to what's going on in the digital world. And this is a big concern, as you can gather, for many people. But tonight I'm just going to mention that, and also the fact that I do various things in relation to health, because my background is I was a nurse and a midwife. And after I retired, I decided to continue various aspects of that and in regard to research and various health groups. And one of the health groups I'm on is about the secure data environment. And I don't know if any of you have heard of the secure data environment projects which are going on in the National Health Service. But I thought that was an interesting thing to get involved with for my job. It's not a job as many people would say, but my involvement as being the editor of the Connections for magazine, but it's like a magazine newsletter, so that I can give people who are concerned about data and AI and what's happening in the digital world more information in regard to what's going on. So this project called the Secure Data Environment, actually, there's about 11 of them in the whole of the country, and they involve people, public and patients, and to give them a voice in regard to research by using people like me on what's called a committee called the Public Engagement Committee. And we were involved from the beginning, and when it was set up in regard to how applicants who want researchers from academia, from NHS, from universities, from this country and all over the world could actually use the data from NHS patient records. And it was what was called a cooperative, a collaboration between sort of the officialdom and public and patient representatives. So what happens is the researchers ask to view various topics on the records, and then a committee above us, you might say, have a look at the applications, and then we send the applications to review as well. Then when the two committees are happy, it goes to the local integrated care board, and they give the researchers, the idea is to give the researchers approval, and they can they can look at the data. They can't download it, they can just view it, and they can only view it under certain specific conditions, and various checks and balances are in place to make sure that it's not, there's privacy, and nobody can take a person's name and find out specific details about that person. So this gives a little bit of information to sort of people like me, you might say, who are involved in that in regard to what's going on digitally. But it was just mentioned beforehand about GPs and what they're doing in regard to AI and digital inclusion. And I'm involved with another group which is involved with monitoring GP practices in the local area in regard to what they're doing with AI. And what the lady mentioned was the fact that about how GPs are using various aspects of AI. And I remember one thing they said they were using is this software called Heidi, or some are using it, which is involved with recording any what happens at appointments for patients, recording what the GP says, what the patient said, so that the records can be accurate. As I say, being involved in these things helps me to understand both sides of the argument, not the argument, both sides of the situation, and the fact that, we are in a situation where, yes, we have to progress. We have to accept the fact that AI is there, and what two other members have mentioned, the fact that it can be very useful in helping people in social care, and I agree entirely with that. But there's a big problem in all this, and that's the fact that it all costs money, and money is and the funding of all these different things for people who don't have a lot of money. A lot of people can't get involved with computers or smartphones because it's expensive, and it's not just a one-off purchase. You might say they've got to keep updating their equipment because, as everybody knows, smartphones every 2 years. A lot of people get a new smartphone. I'll not mention the brand name, and this is very problematic. And also the fact that a lot of older people have never used a computer and may be very nervous about that. And you hear scams and everything all the time. And at the same time, there's an aspect of all this which is worrying for many people, that they are stereotyped by various bits of, not necessarily software, but things which are created in regard to some algorithms. And this actually makes them nervous of how to approach people in healthcare professionals. So there's a lot of complicated aspects to this that really need to be considered. And yes, I'm all for the aspect of AI being involved, but people have just mentioned things about the fact that AI can be used in various care situations. But as I get back to the topic, it's the funding from the government, the funding that people haven't got themselves, and the fact in our newsletter we try to reach out to people and explain that if they've got a problem, we try to advise them how to solve, where to get help. But unfortunately, it's not necessarily the case it's easy to come by. And the problem is, I think, and lots of the people, I'm sorry to say, are afraid that if they become stereotyped too much, and the various aspects of using what's called tools, which involve lots of questionnaires, which are very generalized in relation to not just healthcare, but society in general. Therefore, we become less, the person becomes less of a person, and it's just people become a number. And we need to realize that people, as somebody said, people are not numbers, they are people, and everybody's needs, their situation to be considered in a specific to them. I know that's not easy in relation to the way society is today, but actually it is, because AI and computers should make it easier than what it was when somebody mentioned about the Industrial Revolution, when communications were nothing. We didn't have anything in comparison to what we have now. And I'll shut up now. Sorry, I went on. I've on my high horse about these things. Thank you.
Thank you, Violet.
Yeah,
Thank you.
Thank you.
Many questions for her, also many comments. But last but not least, Matthew Douglas. Again, please tell us. And you have a unique perspective on this too, so tell us.
Oh, well, first of all, I have a background in healthcare going back sort of 30 years. I've worked both supplier side, developing systems. I've also been an IT consultant, and I've also worked provider side with NHS and private hospitals. So I'm someone that sort of sits across the divide and can see both sides, which does help significantly. I guess taking some of Violet's points about digital divide, and I want to start with that because I think it is really important. We've been doing a lot of work with Health Watch in our area, and the one question every time has been, what about those that are digitally disadvantaged? And we certainly have been looking at making sure that even if we do bring in things like digital triage in primary care, that people can still walk in, they can still phone, they can still get that assistance with getting a because not everyone can fill a form in on their own. So we have made sure at every stage that we're looking at that and remembering it and not just being dismissive. I'm reminded from the late 90s when I worked at Ericsson in the very early days of mobile phones. And we were very excited about some of the first smartphones before Steve Jobs came along and ruined it all for us. But we had a great time at Ericsson in the early days. And we'd sort of said, well, you know, Silver Surfers, don't worry about them as a market segment. And we were quite dismissive, I have to be honest. We were quite dismissive back then about them. And I've been proven time and again wrong by, well, that's marketing information has been proven time and again as being very wrong. Because actually, those that do have a device are very good at mastering it. They spend the time, they work it out, and actually having an age range of users when you're trialing software development, which I've done previously, you know, you found that your Silver Surfers were the ones that found the bug before anyone else, because they just keep at it until they found something that wasn't quite right. So I want to be complimentary that, you know, that actually the age group has proven to be very useful. And as long as we deal with the digital divide going forwards and make sure that they still have access via phone or in person. And I find it disheartening when you hear about GP practices that are discouraging people from walking in and so, oh, you've got to go and fill the form in. And I find that very sad, because that's not really the way it should be. So we do need to look at that going forwards. I just want to, you know, part of the whole, why are we doing all of this? And, you know, we know there's already enough more demand than there is supply. But we've been looking at the new hospital builds, and my patch have a significant number of the new hospitals being built in the east of England. If we look at the numbers and the way the volumes are increasing year on year, even if we build those lovely new hospitals and close the old ones, because of course they've got dodgy concrete, we're not going to have enough beds. So we already have a fundamental problem, and that's where we've talked about this left shift and new care model. So how do we keep people happy and healthy nearer to home? We don't want people to have to go to A&E and suffer that, you know, horrible experience of sitting there for hours to get seen because there isn't any other access they can reach in a timely manner and they're not feeling well. So how do we keep people happy and healthy at home? And there's very good data from overseas where it's been successfully done already. So this is not something that we're doing that's new. It's already proven elsewhere, and we just need to reorientate the NHS as a, and it's not one oil tanker when you describe the NHS. It's about 5 oil tankers strapped together. So trying to get that to turn and change direction is a big challenge. But, you know, how do we create that left shift? How do we, and move towards what is called an integrated care model? So we currently have a lot of primary care data with the GPs. We have hospital data if you've been and had an episode of care or at a hospital or more than one hospital. And there's social care data, mental health, community nursing, etc. And they're all on different systems. Some of them talk to each other well, some of them talk to each other less so well. And what we need is a longitudinal record about you as a patient, that we need to have all that information in one place so that all those providers have a 360-degree view of what your needs are. And let's be honest, we have an aging population and we have a declining birth rate. So there's going to be, you know, it matters for me as much as it matters to my children, because we've got an increasing challenge of how we resource this. It's not just about the integrated care piece, but the people who are going to be clinically able on the ground to provide those services. So, you know, we need that longitudinal care record, and that's a very different model to what we have. We have a shared care record already, which is great. We've broken a lot of the old silos around information sharing, and we now do have a shared care record where I can see everything about a patient, including some of their social care data. And that's really important because those flags come in, and that means that we can think about safety, patient safety, you know, etc., as part of that treatment. And there are some really good outcomes from that, where a 111 call has identified something. It's not necessarily in the caller and the problem they've got, but it's in their child and making sure their child is safeguarded. So that's really important to accentuate. You know, we've finally got there with shared care record. We now need to move on and have an integrated care record so that we can see who else is coming to see that person at home tomorrow. What are they delivering? Can I give them a task? Because, you know, that community nurse at the moment relies on phone calls and emails to liaise with the other caregivers that go in to visit that person. And it's not as integrated as it needs to be right now. We've got some needy users out there in the world, in the communities. We call them high intensity users. And they need a lot of touch points. They create a lot of touch points. And, you know, if we can do a better job around that integrated care with them, that is significant savings in time and resource for, you know, for everyone else to get more access. So, you know, you've only got to go and talk to a GP and say, you know, who are your 2 frequent flyer patients? And they'll go, oh, you know, it's this person and that person. And it's not necessarily health. It's the whole picture of what their well-being is, and that they're lonely, they're probably living on their own, they're not coping. And, you know, we've got to deal with those as part of this whole equation. So how do we create that wraparound? How do we make sure they get the right amount of tea and empathy locally, near to home, community hall, outreach nursing at a community clinic, whatever, so that they don't keep bouncing back to A&E unnecessarily. And they don't want to go there either, for that matter. They see it as being no other choice. And from that, we've also got initiatives like cardiovascular disease. How can we identify patients and make sure with that longitudinal record, how can we find people who are not yet unwell and get them on the right medications so they stay well? Cardiovascular disease is a classic one. And so that whole longitudinal thing and you know, doing the health monitoring piece, we can do a lot there proactively. And there's a lot of proof already internationally where they've, Singapore's one example, because they are very integrated in Singapore, bless them. And, you know, from that benefit, they've gone out and found a patient who's like a 1 in a million case precancerous with a rare cancer. And they've dealt with it, and the person never actually had cancer because they caught it and dealt with it before the patient actually was unwell. And that's what we need to aspire to. And I think that's really important. Remote monitoring. We're not doing enough remote monitoring. We're talking about it. We're getting very excited about it. You know, I've got a watch. I upload a load of data to Garmin, but that doesn't go into my patient record, my NHS patient record. My doctors don't benefit from that information in any way, shape or form at the moment. So we've got to look at how to do that better. And if someone is needing step up care from GP in the community sense, or step down from acute care after they've been in a hospital, how can we monitor them at home and make sure they're okay? And then, yeah, does AI come into that equation to monitor that patient's well-being and alert and go, oh, you know, that patient with COPD has just uploaded a 3rd set of bad data this morning on their O2 saturation levels. You know, that needs to flag straight away to the community nurse. There needs to be a phone call. We need to follow up with that person, with that patient straight away, and make sure they don't keep declining because they're obviously already on a path towards not being well. And I found from several years ago, when we had patients doing that kind of data and self-monitoring themselves, it made the patient more proactive because they didn't just feel bad. They looked at the data, they saw the graph and went, oh, I better do some more oxygen right now, hadn't I? So it made the patient more proactive, but it also meant that everyone was informed. We weren't worrying about that patient's well-being. And, if you didn't speak to them for an hour because they'd gone to the shops because they were actually coping that day, again, you could see from the pattern of life that they were still okay and they were still ambulatory. AI generally, I think there's a lot of excitement. You touched on it nicely about the fact that it's very early days. So a lot of the stuff that's coming along, and we talked about ambient voice technology, so being able to record a GP talking to a patient and actually transcribe that whole thing and code it. And we're already showing some very good results from that. That's not proper AI, that's just ambulatory voice recognition. So it's recording the conversation, putting it all into a document and then summarizing it properly. But the patients actually in those situations feel much better heard because they get given a letter, they get given a copy at the end going, look, this is what we've just discussed about you. And what we found is that patients are more likely to offer up the other, oh, and another thing scenario. Because we do have patients that come in and talk about 1 or 2 things, but don't actually offer the 3rd thing up because they're almost embarrassed. But the 3rd thing's quite significant, and I'm not a doctor, but the 3rd thing's actually more significant than the first 2 they offered. So we need that kind of conversation to be better documented. But what we're finding from that is better coding, and then better feedback from the patient and better engagement because they felt heard in that consultation. It wasn't a technical Big Brother thing. It was actually, there's a little disc lying on the table, a speaker recording the conversation, and it's all transcribed and it goes into the patient notes correctly. But the important thing going forwards is, well, the most important thing for the GP is they haven't missed something, because GPs actually can be quite selective in what they hear in a consultation. Let's be honest, they're distracted and they're trying to read the notes and talk to the patient at the same time, and they miss stuff. Whereas the ambient voice thing actually records all of it and clinically codes all of it, or offers it up as clinical coding for the GP then to review and accept. So I think AI has a future, but right now it's the assistant version of it. It takes stuff, it presents it to a clinician for them to review and agree to or not. In the same way as we've been using AI around mammography for X-rays, and it's the consultants in reviewing the images have educated the AI as to what is a good mammogram and what is a bad mammogram. And we're now rolling that out into a lot of other areas, such as identifying brain cancers, all sorts of other things we can now use AI for to review images and present an opinion for the consultant then to review and approve. And I think that's the way AI will develop, just in the same way as we're not using Mr. Musk's cars to automatically drive everywhere yet in the UK. We're using the watered down version because we're not quite sure it's there yet, and we're probably right in doing so. And the same goes with all the other cars, not just Tesla. So I think we've got to look at AI in a very safe way. And for an organization, for us, you need clinical safety. You need a senior clinician involved that's driving this, that ultimately is saying, are we happy with this? Is this clinically safe as a next level of AI, of modernization? Or are we going to have to go and do more evaluations to be sure that we're not going to have a 1 in 1,000 occurrence where something goes wrong and it hallucinates or misses the mark? So we're going to have to continue to evaluate these things. The early stuff we're doing is exciting, and it's all about saving a clinician 1 or 2 minutes in a patient consultation. So that's good. We're freeing up that clinician to do something more interesting and more useful in the patient consultation process. They're not having to type all the notes in. They're not having to sit there and review the patient. So AI will sort of evolve as a digital assistant to clinicians, I believe. I don't think we're going to go near clinical decision support for a while yet, because that actually requires a lot of MHRA involvement in safe clinicals and review, and we'd have to validate all of that clinical decision before we could allow that to be used in the wild. So I don't see AI just being used to replace a clinician. I just see it there as being a complementary function to give clinicians more time. And that will evolve gradually as we feel safe with it. And there are lots of new ideas out there, and they will continue to evolve. It is a bit early days. These are big startups. A lot of them won't survive. And the big players who are very established are already working away at their solutions. So the market, at some point they'll bring their products to market, and the market will evolve further. So I think, a degree of caution. I would emphasize that whatever we do around AI, you've got to understand the people and the process and the way they're working now. And an AI over the top of a bad process is not going to make a bad process any better. So you've got to map your processes, and in many cases we haven't done that in a very long time. We just assume that the process is okay, even if it actually is what I call click heavy for the user. So we can automate that and take those clicks away, but why are the clicks there in the first place? Let's look at the process, let's look at the underlying system, and then see how the AI complements that. I think that's everything from me. I think we've sort of covered all the angles, so I think that's probably go to questions at that point.
Yes, so thank you, first of all, thank you.